All right. Well, hi everyone. Thanks for joining us for another Evaluation Cafe. My name is Samantha Hooker, and I'll be the moderator for today's event. The cafe is a long-standing speaker series hosted by the Evaluation Center at Western Michigan University in Kalamazoo, Michigan. So the goal of the series is to encourage a deeper dive into all things evaluation. In a few minutes, I will go ahead and add some links to the chat. Those are going to be so that you can register for our Eval Cafe mailing list so you can stay in the loop as we advertise our upcoming events. The other is a link that will show you the remaining schedule for our fall speaker series, and we are just finalizing dates on our spring series, so those will be in there soon as well. Before we begin, we do take a moment to acknowledge the history of the land we're on. Western Michigan University is located on the ancestral lands of the Three Fires Confederacy, which was historically occupied by Ojibwe, Odawa, and Potawatomi nations, and we honor their stewardship and connection to this land. Today, we are excited to be joined by Mary Gayen, manager of the evaluation team, Elaine Bartley, evaluation specialist, and Julio Cano Villalobos, evaluation specialist senior, all of Corewell Health. So if you have any questions as we go through the presentation today, you can enter them in the chat at any time they occur to you. I will keep an eye on that. We'll ask them during question breaks. You can also use the reaction button that you'll see on your screen to raise your hand, and then we can address you when we take question breaks. With that, I will hand it over to our presenters.
Hello, everyone. Can everyone hear me all right? I think so. Okay.
Yes.
Thank you, Corey. So good afternoon, everyone. Thank you for being here. And thank you, Samantha, for thinking of us as being worthy to present here. And we are excited to be here, and we're excited to take questions. We do not promise to have the answers, so you might hear a lot of I don't knows. But if we have answers, we will share them with you. So my name is Mary Gayen, and I am the manager for the evaluation team. Before I proceed, I'm just wondering, like, are you all seeing the screen as presenter slide, or are you seeing it divided? How are we seeing
We
it?
see
You seeing it?
presenter mode.
Okay, all right.
Oh, there it is.
There you go.
There it is, yeah, because, okay, not Elena giving out our secret notes. Okay. So a little bit about myself. I moved to the US to pursue my master's in social work in 2017 and have been a part of this place for the past 8 years. I lived in Trinidad and Tobago, which is an island in the Caribbean, before moving to the US, but I'm originally from India. So, but when people ask me where I'm from, I typically just say Trinidad and Tobago because that feels like home. That feels like I belong. It feels like acceptance. And it's also the happiest place alive. If you've never been to the Caribbean, you should. And this is the best time because it's going to get cold and sad and rainy. So you know, make a plan. I started with the evaluation team, or my evaluation journey, as an intern. And I think I'm here today because of the kindness of a lot of individuals that decided to take time and teach me how to be an evaluator. And a lot of them belong to the Western family. Like Corey's here. I don't know if Liz is here, but it is, you know, the kindness of these individuals that have kind of given me this advancement of leading an evaluation team. Because as you can see, I mentioned that I came to pursue my master's in social work. It had a class on evaluation, which not a lot of us took seriously, but I did. So here I am, and currently live in Southwest Michigan. And, you know, I'm still part of the Corewell Health team. And thank you for having me. I know Elena, Julio, which one of you would like to introduce yourself?
Go ahead, Elena.
Sorry, Julio, did you say you were going to go?
Oh no, I said go ahead.
Oh, okay. Yeah, for sure. So I'm Elena Bartley. I grew up in Kalamazoo. I went to Kalamazoo College. I studied biology there. I have worked many different jobs in healthcare, and pharmaceutical industry. But yeah, I ended up doing my master's thesis with Corey Smith, who's on the call, and then Mary back in 2021. And that's where I discovered evaluation. And so although I did, depart from them after my thesis, I did come back to work with them in 2024. So yeah, I've been on the evaluation team for about a year and a half now, working with Mary and Julio and Corey.
Thank you. And my name is Julio, Cano Villalobos, and I'm originally from Chile. I studied anthropology, and I sort of been further in my studies by getting a couple of other certificates around user research experience and evaluation as well. But for over the past 20 years, or 20 so years, I've been more, before coming to evaluation, I was like a practitioner, let's say, right? So I was doing community health work, mostly with core health, through different programmings and initiatives. And my hobby, sorry, is to go to Facebook and declare the dangers of dictatorship because of my personal history growing up under dictatorship in Chile. So that's what I do. All right, so we're gonna start, right? So, and that was my part. All right, great. So we're gonna start describing who are we connected with. Our employer here is Corewell Health. Currently is the Michigan largest integrated health system, and with more than 60,000 members across Michigan. So we have three different regions: East, West, and South, which are basically Detroit, West Michigan, and some Kent County, and some counties to the north of Kent County, and south that'll be South Bend, right? I think one important thing that I like to highlight is that we're not just a network of hospitals and clinics, but I can say, because of the work that I did in the past, we're deeply connected to communities addressing health beyond, the clinical setting. Next. All right, so this is our chart. And down here, you'll see, sorry, that in order to bring our mission to life, Corewell Health established the Office of Community Health Impact and Belonging, led by Carlos Cubillas there in the picture. And Carlos is Corey's, who you very well know, is our director, right? So this office unites community health, belonging and inclusion, and health equity. And that ensures that our strategies address the root causes of inequities and strengthen community well-being. Next. So our team, our leader team, is called HEAT, the Health Equity Evaluation Assessment Analytics. And at one point it was called Transformation. You can ask Corey if we still have that title there, team. And we provide the evaluation backbone to this office. Our mission is to collaborate with team leaders and communities, equipping them with infrastructure, information, and insights to guide strategic decision making and drive equitable transformation. We embed evaluation directly in how the organization plans, invests, and learns, most importantly, right? So this team oversees three major areas of work, probably more, but I'm going to describe three of them. Our evaluation work. So we have a sub team called the evaluation team, provides evidence for decision, accountability, and transparency. We have our community benefit investment portion areas. And so we have community benefits on that side, keeping records of all of our interactions with communities. and we lead also the community health needs assessment in all of these regions, right? We bring forward data and community voices to guide organization resources. And a third bucket is analytics, and part of our team is actually embedded and within the larger organization in the that data and analytics department. I don't know the proper name of that department, by the way. And that actually allowed us to access system data that we wouldn't otherwise have. Right? We didn't have that before. And that helps us to connect all these elements, all these elements that you see on the screen with metrics and evidence that we are now able to gather, right? Next slide, please. All right, next one, I think it is. Oh. So I'm on it's slide 8. Sorry if I confused you. All right. So our presentation today is paying attention to the work of the evaluation team under Carlos and Corey's leadership. As I said, we support belonging initiatives, what used to be called DEI, and also broader equity integration efforts across the organization through internal partnerships. We call this the System Equitable Outcomes Initiative. Much of our reflection today comes from our collaboration with Health and Communities teams. And this team is basically directing all of our community investments and community programs and through the different regions that I mentioned before, so East, West, and South. They're an essential partner through this journey. And next slide, please. So our team was convened about 2 years ago. And we, again, support healthy communities across all these regions, right? So these are some of the lessons that, we encounter after a year and a half of work or a year of work. And so we realized that, the evaluation across regions was fragmented. We have different tools, we have different expectations, we have different levels of readiness. There was little connection between local program outcomes and system level priorities, for example. Some programs had logic models, some programs didn't have logic models, and community data and data overall wasn't consistently tied to program outcomes. And most of the reports were output heavy. So evaluations often felt like a compliance task rather than a process of learning and collaboration, right? Next slide, please. So these gaps reflected what we called a deep-rooted consultant mindset in the organization. So there is this perception of what evaluators are and what is their role, right? So in this mindset, evaluators are seen as outsiders who deliver reports instead of co-creating knowledge. This transactional view of evaluation left programs without ownership and disconnected the evaluators from ongoing improvement cycles, right? So the learning loops were broken and evaluation came after action usually, right? Instead of informing it along the way, no? Next slide, please. So to sort of opposition to that consultant mindset, we in our team are proposing a different mindset, and that mindset is the one of the stewardship, right? We are working towards this different model of a different role about, for our team as evaluators. That one of not it should be called shared stewardship, especially in the context of these community benefit programs. Stewardship means evaluators and programs team teams share responsibility for how community benefit resources are used and what impact they achieve. It's about mutual accountability, trust, and transparency with the communities we serve. We are cultivating co-design practices and building evaluation values grounded in equity, collaboration, and shared ownership. Next slide, please. If you just want to click all the way. So this mindset of shared stewardship sort of like inspire the creation of what we are calling right now the healthier communities evaluation architecture. You know? Is a summary page that you see right here displayed on the screen is describing three different spaces. No, you see a strategic space, an operation space, and an infrastructure space. Hopefully, you can see the entire screen. We usually say these spaces are all interconnected. This is a summary page of a much complex diagram that we created originally. But these elements are connected, and we say these are the elements that we need to do our work. No, the architecture is not only sort of a technical guide, but it's more of represents a cultural shift, defining what we need in our environment to collaborate effectively with regional decision makers and help us align systems and regional priorities, builds evaluation readiness, and leverage that data systems that sustain continuous learning. And the questions and questions and answers, we can discuss more about the the details of this architecture, which is sort of our map. But before handing it to my partners for the rest of the presentation, I'd like to, next slide, please, sorry, to share a little bit about our work around that part. Go back, sorry, one too far, yeah. So I've been working with Corey and other team members into this section of the evaluation architecture. No, this implementation is been ongoing. Some components are still in planning, others are being tested, and all require iteration, flexibility, and patience. Right now, for example, we are, as I said, engaging healthy communities leadership in identifying priority indicators. No, key measures that will connect program outcomes to our equity strategy. This process so far have resulted in the identification and selection of 15 community priority indicators identified across 5 outcome areas, which are the problems. We call it outcome areas are the problems that we want to solve. So each one outcome area has 3 community priority indicators. So we have 5 of those. So we have 15 indicators, and have so far yielded the creation of a library of priority indicators of 88 indicators that are connected to each one of these outcomes. And Mary's gonna talk about our portfolios of work, but that's what we have done in part of this process. So this process is ongoing. We're still working on this. We hope that this is gonna be result and a better alignment from the community programs and more awareness and communication from the leadership of these programs and their teams, to have a common goal and it facilitates our work towards our evaluative work, right? So what really we are building here is not just an evaluation system, it's a culture of shared responsibility and learning. Evaluation becomes a bridge between leadership and community, between evidence and action. So I'm gonna hand it out to Mary right now to continue the operations part of that architecture and some of the challenges and learnings from the past year.
Okay. So before I move on, I was wondering if anyone had any questions around the context and our situatedness that Julio just shared about. You can either come off mute, ask the question, or you want to put it in the chat. I can move forward.
Yeah.
Okay. So, as Julio shared with you, the whole strategic piece of how our work is the strategy, I would really like to talk about the operationalizing of the strategy. And you will see there are different elements on this layer of operations, right? There's the regional evaluation committees, there is the regional evaluation portfolios, there's program evaluation, and all of that kind of tied into our evaluation readiness levels. So I'm going to walk you through these different elements that make up the operations, and then we'll share with you some kind of use cases that we have been working on. And like Julio said, this is a work in progress. We are calling it the evaluation architecture. So we're really like building one brick at a time. And it's been quite the journey for us. So that's why we've called the presentation a journey of, evaluation through the system, through the healthcare system. So in the next slide, Alana, if you would move forward, I just also want to share with you the way the team has been approaching work. And it comes from, just really understanding our programs, right? So like Julio mentioned, there is the East, West, South, and then we have the belonging team that we support and the equitable outcomes team that we support. So the way we try to really approach work is understanding like, what are these perspectives, right? How is our team situated, where it is situated, and what's going on at that time when a certain service or initiative is being implemented. And of course, there is the facts, which is, we look at the data, and then we kind of make those evaluative judgments in collaboration with, as we advance through the slides, you will see who is at the table when we're having these conversations, and how we've been able to really co-create and collaborate with different teams. So I just wanted to share this approach that the team takes in the process that we try our very best to implement. So we'll move forward with the operations piece of it, right? We talked about regional evaluation portfolios. I just want to kind of level set and touch on really why we decided to take this portfolio approach, right? When you think about all the work that our teams do, there is this approach of, in the West, we have a certain program, the South, we have a certain program. So it's almost like here a program, there a program, everywhere a program, and then you have these several tools to measure them. So what we were not doing was kind of...
I did mute that go. Oh, I did mute my ear,
I thought he had a question. I was like excited. Anyway, so we, from all those gaps that we were able to identify that Julio talked about, one of those was this, right? That we have a lot of work happening. It's just not presented in a collected, cohesive manner. And so from a lot of learnings, we've worked with different consultants like Health Begins, and, they really also emphasized that why don't we as healthcare systems really talk about our work in a more, yes, we will. So, why don't we come as one and share our work as this like one more cohesive portfolio of work, right? Because in the next slide, here's an example, right? Instead of really like doing this patchwork evaluation, if we had portfolios that were more inclusion focused, right, and talked about our strategies, and then we measured them from that perspective, we will be able to showcase the value of the work we do. Because it's important for us to remember that our programs, right, collectively also really contribute to our community's health. It is not the only factor that is impacting health. There are these other, like the environment that individuals live in, or their other systems that they interact with. So we are just a small contributing factor. And if we were able to talk about it from the perspective of, here is a portfolio of work that we do, then we're able to measure it also based on the portfolio of work and impact that our team has. So just to kind of show you like a physical representation of, you know, what a lack of portfolio approach could do. So in the next slide, Alana, we have, you know, an array of programs. But now, if you move towards a portfolio approach, right, we have been able to craft, in the next slide, we have 3 portfolios right now for healthier communities that, you know, we've been able to work with the healthier communities leadership and craft place-based care and wellness, as community building and civic engagement, maternal, child, and adolescent health outcomes. And you will see that there are different programs that belong to these portfolios, but when you talk about like to what extent have these portfolios impacted health, you're able to share a collective, cohesive evaluation for it. So another example of portfolios, you know, I pulled out from the Othering and Belonging Institute, is this is how they kind of measure their work as well, right? They have the Bridging and Belonging or Climate Justice. These are the different portfolios of work that they measure around. So that's another example. I see there's a question in the chat. Maybe I can address it. It says, can you give some examples of the types of programs you evaluate? Okay, sure. While Alana is going to talk about it, but we have programs around maternal infant health, right? They're broken down into education. So we have classes around prenatal education or positive parenting classes. It's called Triple P, or Raising Resilient Children. And then we have programs around place-based care, which is, you know, some of these programs, they work towards managing or impacting chronic conditions. So there's a program called Centered, which teaches individuals that are at risk or have hypertension on how to cook for yourself and manage your hypertension. So you see there are these different types of programs that are in different regions, but at the end of the day, their goal is either manage chronic disease. So we have Centered, then we have some fitness programs, we have a running club. So there are these different programs that fit in these portfolios. So that's some of the examples. Now, we'll move forward to this term that we used called the evaluation readiness levels. And I'm sure it's not new to you all, but I will just kind of share with you where we came from, right? When we were looking at all of our programs, we realized that we didn't really have I want to say more like a standard of, like, how do we determine, right, if a program is ready for evaluation? What are the tools, the basic, like, fundamental tools that the programs have? And so the team came together and we did a lot of reading around evaluability assessment, and we created a tool. And now, as you would realize, that the team has Julio, who is an anthropologist. There is me with my social work background. We have other individuals on the team from public health. So we always take a lot of these concepts and then make it our own. So we were able to do that, and we created a scale, and we walked some of our programs through that, and we created this scale around from level 0 to level 4. And I'll describe those for you. And what we did was we sat down as a team and worked through these programs and said, what criteria does this program fit? And then we had like a scale for it. And then we moved forward. We said, okay, we're going to slot this at level 0. Moving forward, take another program, work through it, you know, slot it at level 1. So we were able to kind of categorize these programs based on the information that we had. So a level 0 program essentially is a program that does not have a logic model, has no beneficiary population, or even a resource personnel to work with us on evaluation, which we found we did have quite a few programs that we just knew about. And there was some kind of like infrastructure where they were collecting data, which was not aligning with, our strategies or with our, say, CHNA or the health equity strategy. So that was a level 0. Now, a level 1 program is one that has a logic model, has a population that they're kind of aware of that's being served, and they had sufficient resources to engage in evaluation with us. So we found we had quite a few of those programs. In level 2, we have a program that has a logic model that is plausible. The beneficiary population is equitable. So, we go through really filtering out, okay, there's an eligibility population. All right, now let's talk about the target population. And then we filter it down to really the equitable population that needs to be served in order to kind of fill in those gaps, whether it's a death gap or, improve a certain health outcome. That's your equitable population. And we've also, Julio's developed an outcomes framework for us. So, we've been able to really develop certain tools to share with our programming teams to kind of empower them also and walk with us through this evaluation journey. And, we'll have strong outcome statements. And it's, of course, aligning with our health equity strategy or the CHNA or, strategy coming down from our leadership. And the third one is the one that we do these, like we have a monitoring framework for it, but we move forward and now we are trying to create those evaluations, which have evaluation plans, asking key evaluation questions. So these were the levels that we were able to create. And there is a level 4 too, because, we have time. So a level 4 is one that now our team is learning how to do this, is we want to talk about really how our programs add value, right? And so we're learning how to calculate the value on the investment, the social return on the investment, and really talk about evaluation from that perspective, because at the end of the day, of our community health teams need sustainability, and we also need to have the language around around the value of investment or the return on the investment on our community health programs. So we have these, those are our readiness levels. Okay, so we will now move to the next element of the operations. So we've talked about the regional evaluation portfolios. We've talked about the readiness levels. Now I want to move forward to the regional evaluation committees. So you notice that, when Julio talked about the gaps, there was like a little bit of a lack of infrastructure around what's being collected, around what are the programs that are being prioritized, right? And so when we were thinking, how do we engage leadership a little bit more than they're already engaged, we thought of, why don't we create some regional evaluation committees where they will be given certain responsibilities and we will work in collaboration with them. So we were able to create evaluation committees in the East, West, and South, which consisted of mostly leadership, right? Because there is a little bit of a hierarchy, right? That here is our strategy and now let's implement it. So they had that context and the view around what is priority. And so they were able to kind of give us programs that they wanted us to advance from, like, say, a level 0 to a level 2 or a level 0 to a level 3. And our teams have a lot of different initiatives and services. So maybe a total of about, I don't know, like sometimes it's 70, sometimes it's 60, depending on who you ask. So we had to really take a phased approach and tell them, okay, the evaluation team has 3 evaluators and me, and then there's Julio, who is our kind of like our consultant on the team. So how do we move forward without drowning ourselves? So we've asked each team to give us 3 level 2 programs and 2 level 3 programs so that we're able to do justice to the evaluation that we want to do. And so these were some of the responsibilities of the evaluation committees, right? Ensuring accountability on their end and on our end. We talked about the model with Emily Gates, where we talk about collaboration. So we wanted to make sure we fostered that. decision making and continuous improvement of not just our process, but also, their programs. So these were kind of like their responsibilities in the evaluation operations. Now, I'm going to speed up because, Alana, you can move to the next slide. And I've been kind of talking about the process, right? So we've talked about regional evaluation committees, we've talked about the portfolios, readiness level, and now I just want to move towards like the program evaluation piece of it. What we've done is we've engaged, of course, the evaluation team, and you're probably like, can you go back to the next slide, Elena? You're like, that's obvious, but it's, we've assigned a region to each evaluation team member. But what we've tried to do is really work together on a lot of the elements in this operation. So the whole team is engaged in the work that's done, but irrespective of the region. And then, of course, we have the leadership team from healthier communities or belonging and equitable outcomes that we have conversations with, ask different questions of, and then the program teams. Our program teams typically have nurses, community health workers, program specialists, operations specialists that are all invited to our extensively long logic model sessions. And we share with them prior to even, engaging with this, like, here is what is the effort that you're going to put in, and here's the effort that my team is going to put in. And we try to make sure that we've sent in some pre-work so that we are all kind of not on the same page, but at least in the same book, because it's not easy for somebody to just come in and say, I'm going to craft some outcome statements with you, whereas we've been doing it for quite some time. So that is kind of like the process of operationalizing our programs. And I see there are some questions in the chat. I see Corey has responded. I will respond to it. And this is just kind of like the communication that we send out to the teams that, here's what is required to advance from 1 to 2 or from 0 to 2. So Elena, you can move forward. So Elena is going to walk you through some of the work that we've been doing right now. An example of portfolios, putting portfolios together, is what we did. Nathan and I worked on creating these portfolios for our belonging team, and we were able to slot it based on the priorities that came from the leadership team. And then we developed learning and development and policies and practices and workflows development portfolios, so that we're able to measure these different portfolios at the end of the year. And the way we did it was really walk through their current services and initiatives that they have within the organization, and then understand who they're being targeted to, what is the kind of work that happens. And then we were able to slot it in these different portfolios, share it with the team, get their feedback, rework, share back, and then get their approval before we move forward and kind of crafted these shared outputs. We have shared outcomes for these as well. So this is an example of what we did for the belonging portfolio at Corewell Health. Elena.
Right. Okay. So I'm just going to move through these kind of quickly, but here's an example of some system level work we do. The evaluation team has been working with the Health Equity Expert Improvement Team, or what we call HEEIT, and we've been working with them to evaluate the concept of upstream quality improvement. So this work is grounded in equity promoting integrated model for clinical and social care, which bridges clinical care or healthcare and community health strategies. So while focusing on this concept of upstream QI, which in a clinical setting refers to proactive strategies aimed at addressing the root causes of health disparities and poor outcomes by focusing on social, structural, and community level determinants of health, rather than only treating symptoms or conditions as they arise. So to begin evaluating this initiative, we work closely with 4 different teams who are involved in this overall upstream QI initiative to create logic models that accurately captures their outcomes and the long-term impact of integrating equity into clinical care. So along with the logic models, we examined the 4 domains to the left of the screen there in the 4 different boxes. And this was to assess where changes were occurring and where changes are not occurring. So we found that the workforce competencies are focused on the individual knowledge, skills, and beliefs of practitioners, especially regarding the upstream quality improvement and equity. For the organizational capabilities, those encompass team or departmental level abilities, such as having clear plans and tools that are directly related to equity and social needs. For system capabilities, this involves collaboration and relationship quality and density between different teams or departments, as well as management, governance, and data systems at the organizational level. And lastly, we have ecosystem capabilities, which pertain to the organization's ability to collaborate with external partners, community organizations that extend beyond those internal systems. We were also able to dive deeper into this work and create different tools to measure those outcomes from those 4 different teams. So for some, we developed like mixed method surveys. For others, it was like refining their existing surveys to meet evaluative best practices. Also, I don't want to go over time, but is it like a hard stop at 12:40?
No, we'll stop by 1.
Okay.
But if we could leave maybe like 10 minutes for questions,
Yeah.
but actually a lot have been answered in the chat as well, so make sure you keep an eye on that. But yeah, you're okay. Keep going.
Okay, cool. Okay, so moving on, this is our evaluation question for this health equity EIT work. So we were wondering, to what extent has the QI process achieved the intended integration of equity into clinical care? So to answer this, the evaluation team developed an upstream capability rubric, which contains 10 domains where the unit of analysis is upstream QI. And these domains reflect an ideal state of equity integration inspired by the concept of targeted universalism, which is a policy and practice framework that aims to achieve universal goals through targeted strategies. This recognizes that while everyone should have access to the same outcomes like good health or education, different groups may need different supports to reach these outcomes due to varying starting points and systemic barriers. Also important to note, this program, sorry, I was just moving on. I wanted to like also kind of define the upstream QI process so that it is our rubric assesses the upstream factors, so like community partnerships, data infrastructure that influence health outcomes by indirectly shaping the conditions in which people live, work, and receive care. So this rubric draws upon evidence collected from those 4 teams employing the upstream QI process. And this allowed us to standardize evaluation across those different efforts, integrate equity into existing QI infrastructure, and it also aligned with our evaluative reasoning, which is criteria plus standards plus credible evidence. So each domain was assessed to determine how well the QI initiative is integrating equity principles into its design, implementation, and outcomes. I'm just gonna move on here. So another example of the work we do is the maternal infant health program. So this is going to be where we do some program evaluation. So MRHP is an evidence-based initiative designed to improve birth outcomes and early childhood development by providing evidence-based care, coordination, education, and support services to pregnant individuals and infants through community partnerships and data-driven evaluation. This program operates on all levels of transformation, so it addresses individual behavior change by directly supporting clients' health-related social needs and medical determinants through risk assessments. It addresses organizational change by refining internal policies, practices, and systems, such as like improving data collection. For community change, it's targeted through active engagement with local agencies, building partnerships, and participating in community meetings to influence broader social determinants of health. And finally, at the structural level, this is approached by it contributes to policy discussions and advocating for reforms at various levels, including efforts to address barriers like doula access or integrating best practices into public health systems. So this work is guided by our evaluation framework again, where we use logic models, key evaluation questions, indicator matrices, and equity and impact. Here's just a quick example of the work that we did with the maternal infant health program. So we developed our key evaluation questions after doing the logic model. We were able to break down the work of maternal infant health into 4 different domains. So here I'm giving an example of domain number 4, which is the healthy development for infants. So once I'd come up with outcomes for each domain, I was able to come up with some evaluation questions, and I put 2 evaluation questions examples up there. So you can read those right there, but in this kind of matrix you see here, I started this indicator matrix, includes each domain, and the evaluation questions, which are in the purple here, and then, the indicator data source, timing, analysis, and sense making of it all. So, yeah, that is a brief overview of some of the work that we do at the program level. So yeah, thank you for listening to some examples of our evaluation work.
That's great. Thank you all so much. Oh, the slides beat me to it. Look, Elena, we're in sync with each other. Please go ahead and use that reaction button to raise your hand if you'd like to ask questions. I'm going to give everyone a moment to just kind of, get their thoughts together and questions. Pop it in the chat if you want. And I thought I would just go ahead and read one of the questions that was answered in the chat so that it's on the video. So one of the questions that was asked was whether you have internal, since you're internal to a health system, do you have access to patient level data? The answer is yes, they do have this access. And circled back to Julio talking in the beginning that the data systems were disjointed and variable when we started the work. So they're in the process right now of moving more things into the electronic health record system, which is going to help standardize the type of data they're collecting, while also giving the ability to better understand the impact. One question was around resources. So whether, what kind of resources are we talking about? Are we, is it usually people and time? Is your group paid for services? And what other resources are essential? And the answer to that was that the resources are mainly people right now. So for example, does the program have enough staff time to engage in the processes we need to go through to design and execute an evaluation? And then when their team does seek grant dollars, they do ask to be written into budgets for evaluation services. And the dollars do end up going into the cost center since the employees are salaried. And then we had a laughing face that then the money can be used for fun things. So I'm hoping that Corewell Health is going to invite us to like a bounce house day or something. And I think, unless I'm missing anything in this chat, I think that covers it. But I, would love if anybody has any questions, feel free to raise your hand, come off mute, and we have a couple minutes left to address those.
I have a question.
Yeah.
Elena, you were showing the maternal and child health and mentioned that you're studying gaps in terms of integrating equity into the clinical programs. I wonder if there's an example of a gap and how you identified it and where you go forward in terms of filling it.
Yeah, so some of the gaps that teams were experiencing were like in so like if we look at data collection, we work with Epic for our electronic health record, and we were finding that there were no like workflows or pathways for like screening women like earlier for like postpartum depression. Sorry, these are for in the context of maternal infant health. So like mothers who are getting screened, with those tools in Epic, there was no way to screen them earlier. And so with this concept of upstream, we want to be able to determine if, you know, we want to find and like flag those people who are maybe at risk for postpartum depression. And so we had to work with our EPIC team and clinicians to make a pathway or to make like a form in EPIC that allowed us to document or start documenting the screening services for those women. So yeah, I would say like if, you know, we do find a gap, we you know, find a way to fill it. But that's just one example of how we filled it. We worked with, you know, our EPIC team.
Thank you. I guess I'll ask just a follow on to that. If when you find that postpartum depression is a gap in terms of identifying that and the women you're serving, well, was that an intuitive leap to think about that question, or was it data driven in terms of what EPIC analytics showed, or how did you actually get to postpartum depression as a gap?
Yeah. So so the team that specifically is so like of the 4 teams within this upstream QI work, one of the teams is specifically for maternal mental health. And so the physician who's leading that team, she noticed there was a gap, and then also there's lots of like data literature that backs that up. So you know, along with the physician and then also like peer-reviewed literature, we were able to decide that.
Okay, thank you. Very good.
Hi,
Oh, sorry, go ahead.
this is Val. I'm in the room. Can you all hear me okay? Yeah, online? Okay, well, no one said anything. So
Yes, we can.
okay, thank you. I know that the kind of work that you all are doing, focusing on root causes, like this key, which is, you know, key to equity work, structural level factors, that with that comes sometimes some navigation around different ideas, beliefs, politics that can make evaluating that kind of work tricky, or engaging in that work tricky. Did you all run into any of that? And what would be your recommendations for other evaluators who are evaluating these larger structural issues? And then you can write that up for a dissertation.
That
You
is
don't
an
have a choice,
excellent
Mary.
question. But I will ask Corey to take that because he's our leader and we have thus far. Yeah, I want him to take that. Corey, can you respond?
Well, I think Julio has a response, maybe.
Oh, he does? Okay. Mine, I'm going to
mean,
put it in the chat.
Sort of pitch in anytime, right? So we we are coming from an organization that has embraced equity or the word equity for many years, right? And again, I'm sort of a witness of that, you know, at working at the program level before I joined the evaluation team, right? But one of the things that we noticed is that the many of these desires for equity were not necessarily operationalized, but they were put on statements, but not necessarily operationalized, right? So in order to bring that into reality, we've been doing other efforts as an evaluation team to around mindset shifting, you know, about having conversations with leaders about what actually equity means. So for example, right now I joined thanks to our program and our resources. I was able to join a community of practice around targeted universalism because we noticed that, you know, a lot of people talk about targeted universalism and equity, and we all embrace it. But in practice, we started noticing that, you know, people did not necessarily follow the steps or did not dive into data, create a universal goal, disaggregated the data in order to see how the groups were, you know, faring against the universal goal. And we felt that, you know, target universalism was giving us a practical operational framework that you know that everybody can buy in and get into and get on board. And but when we can't say we are there yet, but we feel that the disposition by the teams is to get there, and we are just arming ourselves, you know, to contribute and bring people towards that. You know, I think that's a level of using the target universalism framework as sort of like a good tool in order to um, soften the potential disagreements they might have around some controversial work that might show up in their work. Right? I don't know if Corey wants to add more.
Yeah, I would add a couple of things too. Like, I think, you know, one is like making sure that I think over the last 5 years working at Corewell Health, I've been on sort of like my own journey to try to like understand that we do have to make sure that we make this work make sense to the business, right? Like it has to be able, we have to be able to tie it into the goals of the organization more intentionally than we have perhaps in the past, especially in times like this. And it feels like it feels like this has been a constant for 5 years where it's like healthcare is going through a lot of things. There's constantly financial pressures. And so like we have to be able to make sure that we are carving out our space in this organization by demonstrating how we help deliver on the organization's goals. The other thing is like finding the people within the organization who can be allies and champions for this work and who see its relevance to what they're trying to accomplish. And frankly, like when you start to break it down, that can become relatively straightforward by helping people understand that what we're really talking about is gaps in outcomes, and recognizing that certain people need certain different things. One of the areas where we've had that success in healthcare is in population health, right? They're really focused on trying to understand the whole person and what they need, and looking at different subgroups to make sure they're delivering the right programs to the right people based on those needs. And so I think it's also about finding those allies and finding those champions who can start to work with you to demonstrate how this looks. And then on the structural side of things, you know, I think our ambition is to, you know, get at root causes, is to work on structural solutions. But, you know, what's been challenging about that is it can feel at times, one, overly conceptual to folks, and two, it can kind of you end up in this tension zone of like, what is the role of a healthcare system and what is within scope and what's outside of our scope. And I don't think that answer is like we haven't fully answered that, right? Like, are we an organization that wants to advance structural solutions, or are we not, right? And I think like, you know, regardless of what I sort of think as a person, like, you know, it's a reasonable question, and I can understand why our leaders might say, you know, no, we're not, that's not a thing that we're necessarily comfortable doing, right? And so I think those are the other things that I've observed over the last couple of years.
So Corey, just a quick follow-up to that. Do you think that it's conceptual to people because there aren't readily available measures?
No,
Or how to operationalize it?
It's not that, because the data's there. It's like, you know, one, it's analytic, it's like getting the right support from the analytics folks. I mean, at like the tactical level, it's about getting resources for people to do the disaggregation of data so that folks can look at their metrics in a way that helps them uncover those gaps. And then it's making sure that analytics team is also delivering insights, not just products, because folks need help understanding and interpreting the information, right? And our analytics team is not necessarily a team built to deliver insights. It's really about just delivering products. Basically what that means is just Tableau dashboards, right?
Got
And
it.
so what we haven't really figured out is like, how do you get in front of a group of clinicians, show them a bunch of data, help them identify gaps, but then but then find the next step, which is like, what do we, because what they're going to say is like, okay, what should we do about it?
Right.
And they're all about action and what do we do
Mhm.
next? And like, what does that mean for the next patient I'm going to see, right? And so I don't think I don't think we've always been successful in being ready to answer that next question,
Yeah.
right? And we'll say, well, we want you guys to come up with the solutions, right? But without being able to come to the table with something, they're just kind of like, we don't know what to do, and then they just go back into the exam room and see the next patient, right?
Right. Right. Got it. That's helpful clarification. Thank you.
Mm-hmm.
Hey, well, thank you so much, everybody, for joining us today, and thank you for your presentation. We really appreciated it. We will go ahead and post the recording on our Evaluation Cafe page, which I put the link into the chat. So you can catch up on that if you'd like to, and hopefully you'll join us on November 5th for our next cafe presentation. And I hope you all have a great rest of your day. Thank you.